Any doubt, anything you want to ask? Anything you want to ask? Trauma. Now in abdomen, can you tell me what are the investigations do we have per se for abdominal examination? Ultrasound. One is fast. Any other you know? Now we don't do fast, we do E-fast. E-fast is extended fast. What is extended fast? I'll let you know. Any other investigation? CT scan. Diagnostic. Peritoneal lavage. Diagnostic peritoneal lavage. Right? Now, let us first talk about E-fast. Focused assessment sonography in trauma, which is now extended focus assessment sonography in trauma. In this investigation, we just want to know whether there is fluid or not. This investigation is to check about a fluid, right? Because the concept in FAST is that there cannot be any injury in the body. If there is one, there will not be a fluid collection. Once there is an injury, there is bound to be a fluid collection. So in FAST, we just want to see fluid, right? So the basic intent in FAST is to see fluid, and the minimum amount of fluid it can see is 100 ml. If the fluid is more than 100 ml, one can see through FAST. Now in FAST, what we do, we put probe at 4 places. Very commonly asked question. What are the 4 places we are going to use? Put a probe in FAST. We will put probe in the epigastric region. We will put probe in the epigastric region. Second probe we will put in the right upper abdomen. Second probe we are going to use and put it on a right upper abdomen. Third point of probe placement is left upper abdomen. Left upper abdomen. And we also put probe, the fourth point of probe placement is suprapubic region. These are the 4 points of probe placement in FAST. But now we don't only do FAST, we do E-fast. And in E-fast, we put probe at costophrenic angles also. We put probe at costophrenic angles also. Now, this can be a question in your exam. This can be a question in your exam, that what do you want to see in a costophrenic angle? The basic point here to notice, in a normal scenario, please note this point. In a normal situation, you can appreciate that the lung will expand, and come to the costophrenic angle and will recede back. During inspiration, the lung will expand and come to the costophrenic angle, and during expiration, it will go back. It will come, it will go. It will come, it will go. This is a normal, you know that, right? So in a normal situation, when you put a probe at a costophrenic angle, an ultrasound probe at a costophrenic angle, you will feel as if you are standing on a Goa beach. Water is coming and going back, hitting your legs and going back, coming and going back. This is called sea shore sign. This is called sea shore sign. This is normal. So when you are putting a probe at a costophrenic angle, in a normal scenario, you will see a seashore kind of a sign. If this seashore is converted into a barcode, you all must have done shopping, and when we do shopping, there is a barcode there on the article we purchased, and the people there standing scan that barcode and get the bill to you, right? So like those lines, when comes, it is called barcode sign. And when will a barcode sign come? A seashore sign getting converted into barcode sign, pneumothorax. When air comes in the pleural space, when air comes into the pleural space, this seashore will not be seen. What will be seen then? Barcode. So presence of barcode in a costophrenic angle is suggestive of pneumothorax. Now, let us know the important points about these investigations. Please, this will help you in answering any clinical question also. The first investigation, remember always, the first investigation you are going to do in any patient of blunt abdominal trauma, the first investigation you are going to do in any patient with blunt abdominal trauma, be it stable, be it unstable. What is unstable? What is the definition of unstable? Blood pressure less than 9. So stable or unstable, our first investigation will be fast. Remember, as a rule, right? However, if you are asked what is the investigation of choice for blunt abdominal trauma in stable patient, your answer should be CT scan. Your answer should be CT scan. If you are asked what is the investigation of choice for blunt abdominal trauma in unstable patient, it is fast. In unstable patient, it is fast, right? Then, and please note this point, will help you in answering questions. If wherever you're thinking fast is the answer, listen to this words first and then write. Wherever you think, you know now where the fast will be answered. if you are asked a first investigation or if you are asked investigation choice in unstable patient. Wherever your answer you think is fast, but fast is not in the choice. If fast is not in the choice, then your answer will be DPL. Then there only the answer will be DPL, otherwise DPL we don't do anymore. So DPL is only done in a present time when you don't have a facility of fast available. DPL we don't do anymore. So wherever you think fast is the answer and fast is not in the choice, to that very question only, the answer will be DPL. Okay. So please be careful about it. DPL is not a replacement of CT scan, mind it. DPL is a replacement of दोनों ही नहीं हो तो क्वेश्चन ही नहीं होगा. फिर वो ऐसा क्वेश्चन ही नहीं होगा, फिर वो क्वेश्चन होगा इन्वेस्टिगेशन ऑफ चॉइस ऑफ ब्लंट एब्डोमिनल ट्रॉमा इन अ स्टेबल पेशेंट. यहाँ पे फास्ट और डीपीएल दोनों ही नहीं होंगे आंसर. वहां पे आंसर ही सीटी है तो डीपीएल और फास्ट की बात ही नहीं आई. ठीक है. Then comes investigation of choice for penetrating injury, abdomen in unstable patient. First of all, you should know this. What is the definition of a penetrating injury? When will you call injury to abdomen a penetrating injury? A question asked. No, not breach of peritoneum. Very good. Breach of peritoneum is a penetrating injury to abdomen. So if you are asked, what is the investigation of choice for penetrating injury abdomen in an unstable patient? You know what is unstable already now. The answer is exploratory laparotomy. Your answer will be exploratory laparotomy. Right? But if you are asked, what is the investigation of choice in penetrating injury abdomen in a stable patient? Your answer should be CT scan. Your answer should be CT scan. Right? Now, can you tell me what is the most common organ injured in a blunt abdominal trauma? Blunt abdominal trauma ये सोच के तो होगा नहीं कि पहले लेफ्ट में हूँ या राइट में हूँ. Blunt abdominal trauma तो कॉमन है ना. So most common organ injured in blunt abdominal trauma is spleen. But please be very careful. If you are asked what is the most common organ, hollow word is important. Most common hollow organ injured in a blunt abdominal trauma. Proximal jejunum. Proximal jejunum, followed by terminal ileum. Followed by terminal ileum. If you are asked most common organ injured in a penetrating injury abdomen, अब तो लिवर मान लो, मान लेते, it is liver. But please be very careful. If you are asked what is the most common organ injured in a stab injury abdomen, answer again will be liver. But if you are asked what is the most common organ injured in a gunshot injury, it is small intestine. Most common organ injured in a gunshot injury abdomen is small intestine. Okay. Now, एक बहुत important बात है, which you have to remember always. Whenever there is a gunshot injury mentioned, abdomen. Whenever there is a gunshot injury mentioned in abdomen, you always have to explore. Once there is a gunshot injury to abdomen, if you are asked what is the next line of management, answer will always be exploratory laparotomy. A gunshot injury to abdomen cannot be conserved. You have to always do surgery. And remember, whenever you are doing laparotomy, whenever you are doing laparotomy in trauma, whenever you are doing a laparotomy in trauma, you always have to give a vertical midline incision. You always have to give a vertical midline. And very important, if the patient is a pediatric patient, if a patient is a pediatric patient, then you will give transverse incision. Then you will give transverse incision. Now, with this understanding, let's see whether you can answer these questions or not. Answer this question for me. Transverse abdomen. A person met with an accident and came to casualty with contusion on left precardium. Patient met with an accident and came to casualty with contusion on left precardium. Normal heart sounds are heard, but there was decreased breath sounds on left side. Trachea is deviated to right. Which of the following is the first line of management? Question समझ आ गया? The choices are needle thoracocentesis or needle decompression, chest tube insertion, pericardiocentesis, open surgery. Very good. Okay. Good. Very good. Needle decompression. Patient has a trachea deviated to opposite side with absent tube. Good. Now, answer this. A 19-year-old gang member. 19-year-old gang member is shot in the abdomen. The entry wound is in the epigastrium to the left of the midline. The bullet is lodged in psoas muscle on right side. He is hemodynamically stable and the abdomen is moderately tender. Which of the following is the most appropriate step? The choices are closed clinical observation, emergency ultrasound, CT scan of the abdomen, exploratory laparoscopy. Good. Exploratory. तो क्या हुआ? क्या लिखा है अभी तुमने? गैंग मेंबर है ना? 19 साल का. Now another question. 45-year-old man comes to emergency room with history of assault with fist and sticks on abdomen. Fist and sticks on abdomen. He is conscious, oriented to time, place and person, but complaining of pain abdomen. On examination, his pulse is 80 per minute, blood pressure is 110/70. Local examination reveals bruises on abdomen. What do you think is the most appropriate next step? Diagnostic peritoneal lavage. जल्दबाजी नहीं है ना? Diagnostic लग रहा है. Diagnostic peritoneal lavage, fast, CT scan, laparotomy. स्टेबल है, बिल्कुल स्टेबल है. नोट देखो. बाय पेनिट्रेटिंग स्टिक अंदर घुसा है. किसने बोला? स्टिक से मारा है. सोचने दो मोदी को, ज्यादा मत सोचो. वो सोच रहा है ना. Fast. Answer is fast. First investigation. तो तू चेंज किया. एग्जाम में भी यही होता है. ठीक है, समझ आ गया. So now, most common organ injured in blunt abdominal trauma, you all know, is spleen. So they commonly ask you about splenic injuries. First of all, there are certain signs of splenic injury which you should know. Like Kehr sign. What is Kehr sign? Kehr sign is pain left hypochondrium radiating to left shoulder. Keher sign is pain left hypochondrium radiating to left shoulder. Then there is another sign called balance sign. Now, what happens in a patient with splenic injury? To understand this sign, you should understand this. Once there is a splenic injury, there is a blood collection. Agreed? And once there is a blood collection, where is the spleen? Left hypochondrium. In the left hypochondrium, the spleen is. So when we do percussion on the left side, what kind of note we get? Dull note. Now, when you shift the patient to right side, when you turn the patient to right side, and when you percuss it again, this dull note will change to tympanic note. So, shifting dullness, shift of dullness to a tympanic note in left hypochondrium is a sign called balance sign. Then there are certain X-ray signs of splenic injury also. There are certain X-ray signs of splenic injury also, like indentation of gastric fundus shadow, obliteration of splenic shadow, obliteration of Schwarz shadow, and fracture of 6th, 7th, 8th and 9th rib on left side. Fracture of 6th, 7th, 8th and 9th rib on left side. Please be very, very careful. In any given question, if you are told that there is a fracture of 6th, 7th, 8th and 9th rib on left side, any injury, if it is there below 5th intercostal space, always think of a splenic injury on left side. Please be very, very careful about it. Okay. Then, if I ask you, what is the investigation of choice for splenic injury? It is CT scan. But please note one very important point. Highlight it in your notes. CT scan is only done when the patient is stable. Your answer CT scan can never be right in any scenario when the patient is unstable. So just be sure about it that the patient is stable in a given question. Right? Now, on the basis of CT scan, there is a grading. You don't need to go into that grading. Not at all required. What is required is this. If you know this, you can answer any question on splenic injury also. What is that? You just need to know the treatment of grade 3 injury. I'll give you a very simple formula of answering a question on splenic injury. Even if you don't know the grading, if you know this, you can answer the question without any problem. What is that? Grade 3 injury is when the laceration in spleen is more than or equal to 3 centimeters. Laceration in spleen, if is more than or equal to 3 centimeters, it is grade 3 injury. Right? Any injury lesser than this, They will not check you whether it is grade 1, grade 2. They will not check you. They will provide you this, that the injury is lesser than this. If it is lesser than this provided, your answer should be conservative management. अगर 3 सेंटीमीटर से कम का लेसरेशन है स्प्लीन में, तो हमेशा आंसर कंजर्वेटिव होगा. ठीक है. अगर 3 सेंटीमीटर और मोर देन 3 सेंटीमीटर लेसरेशन है, तो पहली बात तो दिस इज अ ग्रेड 3 इंजरी. द फर्स्ट थिंग इट इज अ ग्रेड 3 इंजरी. एंड फॉर दिस इंजरी, फॉर एनी क्वेश्चन, द आंसर विल बी splenic for any question, the answer will be splenic artery embolization, except one question. Except one question. What is that one question? When you are asked, what is the best treatment of grade 3 splenic injury? Best. If they ask, if the language of the question says best treatment, then only the answer will be splenotherapy, means repairing the laceration of the spleen. For any other question, please, I am trying to, make things concise for you so that you don't have to remember much. With this understanding, you can answer any question. Any language of the question is there. If best is not asked, your answer will be splenic artery embolization. As simple as that. Right? Now, for grade 4 and grade 5 injury, they will not check you on grade 4 and grade 5 per se. Your answer actually is splenectomy. Now, what incision you will give for splenectomy? Vertical midline incision. Good. Okay. This was about a splenic injury. Now, what is the most common complication of splenectomy? The most common complication is left lower lobe atelectasis. The most common complication of splenectomy is left lower lobe atelectasis, right? But a patient who has underwent splenectomy, the most common long-term complication is long-term. If they specifically ask long-term, it is OPSI. What is OPSI? What is OPSI? OPSI is overwhelming post-splenectomy infection. Because of a splenectomy, there is a risk of infection due to capsulated microorganisms. Due to splenectomy, there is a risk of infection due to capsulated microorganism. In that capsulated microorganism, the most common is pneumococcus. Very good. So we should understand that meningococcus, pneumococcus, even E. coli also. So we should understand that once a splenectomy is done, patient is at a risk of OPSI. So to take care of the OPC, we have to give vaccine to the patient, right? So we give pneumococcal vaccine, the vaccine for these encapsulated microorganisms. So there is a very commonly asked question that what is the best time of giving this vaccine? Post, how will you know in emergency splenectomy? You will in emergency splenectomy. This is a trauma splenectomy, right? In trauma, we will not know that you are going to remove spleen. Post surgery can be 1 month also. Post surgery can be 1 year also. Right? These vaccines should be given in 14 days post surgery, after surgery. Okay. Then the second common organ injured is liver. In balance sign is, what happens is there is a dullness on percussion on the left side once the spleen gets injured because of the blood collect there. When you turn the patient to the right side, this dull note, when you do percussion, will change to a tympanic note because blood has come to the right side now. लेफ्ट साइड में ब्लड था, अब पेशेंट को टर्न कर दिया तो राइट में आ जाएगा ब्लड. अब यहाँ पे जो डल नोट थी वो tympanic हो गई. Right? Then comes liver. In a liver injury, they will not check you on the grade. You just need to know grade 1 to grade 4 injury. Grade 1 to grade 4 injury in liver, your answer should be conservative. Your answer should be conservative. And for grade 5 and grade 6 injury, what is grade 5 injury? If any injury lesser than that is there, your answer will be conservative, right? If more than 3 segment injury is there, it is grade 5. Once the injury is more than 3 segment, it is grade 5, right? Anything lesser than that, we will not be checked on whether it is grade 1, grade 2, grade 3 or grade 4. Your answer will be conservative. For once it is more than 3 segment injury, there are 8 segments in liver, right? If it is more than 3 segment injury, your answer should be explore. And in exploration, what will we do? Packing of the liver. But very important point to notice, whenever the movement of grade 5, imagine there is a grade 5 or grade 6 injury to the liver and you are planning to explore. What incision you will give? Vertical midline incision. If the patient is pediatric, you will give a transverse incision. So movement you give vertical midline incision, what happens is, movement the peritoneum is incised in these patients, immediately a torrential bleeding starts happening. A gush of blood will keep coming. So in that situation, we are supposed to do 4 P's. We are supposed to do 4 P's. What are those 4 P's? Push, Pringle, plug, pack. Ultimately, we have to do packing of the liver though, but you should know these steps. Push, Pringle, plug, pack. Now, the immediate next step, movement you open abdomen in such patients, is push. Push whom? Assistant. Push liver against the diaphragm. Immediately push the liver against the diaphragm. And then you should do Pringles maneuver. This Pringles maneuver can be a question in exam. What do you do in this Pringles maneuver? This is stomach. And this, imagine, is the lesser omentum. right? And you know that on the free edge of lesser momentum runs, what runs? CBD, hepatic artery, and portal vein. On the free edge of lesser momentum, on the free edge of lesser momentum runs CBD, hepatic artery, and portal vein. So what we do in Pringles maneuver, immediately we will apply a clamp. Immediately we are going to apply a clamp, or we can occlude it with index and thumb finger also. Index and thumb finger of left hand or right hand, any hand. When you compress the free edge of lesser momentum with index and thumb finger, you are actually trying to occlude portal vein. You are actually trying to occlude a portal vein, because portal vein is carrying the majority of blood supply to the liver. You all know portal vein carries majority of blood to the liver. So by doing occlusion of this with index and thumb finger, you are trying to decrease the blood flow to the liver, right? This is called Pringles maneuver. And eventually we have to put a mop. What is packing? We take a mop and just stuff in the liver. We will take a mop and just compress the laceration of the liver by stuffing this mop into the liver laceration. Right? So we put that mop inside the liver for the time being, so that the bleeding get compressed. Right? So if you are asked what is the treatment of grade 5 and grade 6 injury to the liver, the answer will be packing. Answer will be packing. Right? Now, this was about a liver and splenic injury. Right? Then comes renal injury. Now, can you tell me what is the investigation of choice for renal injury? For investigation of choice in abdomen, until unless unstable is not told, it is CT scan. Remember, as a rule, only in unstable patient there is fast comes into play. Otherwise, it is always CT scan. Yeah. मेन आर्टरीज को नहीं, पोर्टल वेन को मेनली बताया. Right? Renal injury. In renal injury, now first of all, for any question on renal trauma, first of all, before that, how will a patient of renal injury you think it will present to you? Flank pain, okay, or no urine output. Patient will come to you. Patient of renal injury will come to you with hematuria. Patient of renal injury will come to you with hematuria. Right? And in renal injury, for every question, you can take it for granted here. For every question, your answer is conservative, except these two. Except these two questions. What are those two questions? One, in any given question, if you are told there is a expanding renal hematoma is there, or you are told that there is a major vessel injury, expanding renal hematoma is there, or if there is a major vessel injury of the kidney happens, then only we do exploration. In rest all questions, your answer for renal injury is conservative. What we do in exploration will not be checked at your level. But you just need to know that, see, kidney के साथ advantage क्या है? Kidney has a Girota's fascia around it. Once the kidney gets injured, this Girota's fascia tries to control the bleeding. Right? So we don't do anything once there is a Girota's fascia is able to control this bleeding. But if Girota's fascia fails to control this bleeding, means the hematoma keeps expanding. Girota's fascia fails to contain this bleeding, so it will start expanding. So then we have to explore, or if there is a major vessel injury there. Otherwise, for all question on renal trauma, your answer should be conservative. Exploratory, right? Then comes, this is a very important discussion, and this is going to be a question in exam, because as an intern, you will come across this situation and you have to decide something on these situations also. First of all, there is something called bladder injury. Now, can anyone tell me, is bladder a intraperitoneal organ or a extraperitoneal organ? Extra or intra? It is an extraperitoneal organ, first of all. But in bladder injury, there can be two types of injury in bladder. Extraperitoneal injury or intraperitoneal injury. There can be extraperitoneal injury, there can be intraperitoneal injury. Out of extra and intraperitoneal injury to bladder, can anyone tell me which is more common? Which is more common? Extraperitoneal injury to bladder is more common than intraperitoneal injury. Extraperitoneal injury is extraperitoneal injury is more common than intra. Now, very important, extraperitoneal injury is more common with a pelvic fracture. Whenever in any given question, you are told that the patient has a pelvic fracture, think of extraperitoneal injury also, right? Whenever a pelvic fracture is there, please listen to this point carefully. In any patient with a pelvic fracture, we have to think about two injuries. One, extraperitoneal rupture of bladder, and second, urethral injury. How to find out, how to make out on the basis of the clinical presentation whether it's a bladder injury or a urethral injury is something we have to understand. Okay, how we will decide that? We will get to know in this discussion, right? Now, first of all, out of extraperitoneal injury and intraperitoneal injury, extraperitoneal injury is more common than intra. I just told you, right? And intraperitoneal injury can only happen when the bladder is distended. And the most common site of this injury is fundus. When is our bladder distended? When we have not passed urine for quite some time. So one thing we can make sure in our life, that we will never let intraperitoneal injury happen to us because it only happens on a distended bladder. So moment you have a distended bladder, immediately evacuate because trauma can happen anytime. So if there is anyone who has a distended bladder, please, because trauma can happen anytime. Okay, so what I'm trying to convey through this is that intraperitoneal rupture of bladder one should think of when you are told that the patient had an injury in a distended bladder. Okay, now can anyone tell me, think about it and answer. Once a bladder gets ruptured, because see, you have to start thinking on a clinical approach basis. So when a bladder gets ruptured, can you think of what will be the patient's presentation? Yeah. Pruritus? Bladder rupture से itching? एक मिनट ये सेटल करने दो. With bladder rupture, itching? Why do you think itching will happen? कहाँ confused हो रहे हो? You are getting confused with a gallbladder rupture. We are talking about a urinary bladder. Paramatya. We are talking about a urinary bladder rupture. Okay, sorry, my bad. अब ठीक है? We are talking about a urinary bladder rupture. So what will be the presentation? What will be the patient presentation? Patient ये थोड़ी बोलेगा ये हो रहा है. Patient को there will be non passage of, there will be supra pubic pain also. Now what will be the peculiarity of this non-passage of urine, which is the key point? Patient, will there be an urge to pass urine? Why do we have urge to pass urine? When our bladder gets full and this bladder is injured, so patient will not have any urge, no urge to pass urine. Now this will be the presentation of a bladder rupture. Okay, now how will you know now on the basis of the clinical presentation whether it's a extraperitoneal rupture or a intraperitoneal rupture now? अब ये कैसे पता लगे? How will be known now on the basis of clinical profile provided whether it's a intraperitoneal rupture or a extraperitoneal rupture? In case of a intraperitoneal rupture, means the bladder got ruptured intraperitoneally, so the urine will go into the peritoneal cavity. So when the urine goes into the peritoneal cavity, peritoneal is used to urine in the peritoneal cavity? No. So when urine is not supposed to be there in peritoneal cavity, what will peritoneum does? There will be inflammation of peritoneum. So patient will develop. Now, how will you know that patient is developing peritonitis? Huh? What? No, on clinical signs, how will you know the patient will not come to you saying that I have a peritonitis? What will be there? There will be tenderness in the abdomen. Yes or no? There will be rebound tenderness. Yes or no? And there will also be guarding and rigidity in abdomen. When you put hand on abdomen, the patient immediately have a spasm of the muscles, which is called guarding. which is called guarding. And when the spasm is persistent, even without putting a hand, if the spasm is persistent, it is called rigidity. Initially, the patient develops guarding, and over a period of time, this guarding progresses to a rigidity where without putting a hand, the patient will have a spasm of the muscle, which is called rigidity. When you put a hand, the moment you put a hand, the muscles of the abdomen will go into spasm, right? This is called guarding. And when there's a persistent spasm, it is rigidity. So guarding is a voluntary response. Rigidity is an involuntary thing. Guarding क्यों हो रहा है? Because you have put in a hand. So it's a voluntary response. Rigidity is a involuntary response. So on the basis of these findings, you will come to know first there is a bladder injury, and on the basis of peritonitis, you will come to know it's a intraperitoneal rupture of bladder. Then comes the investigation of choice. How will you know it's a bladder rupture? You have to confirm. You have a suspicion on clinical examination, which you will confirm on your investigation. The investigation of choice here is CT, cystography. Investigation of choice is CT, cystography. While the gold standard investigation is retrograde cystogram. Retrograde cystogram. Retrograde cystogram. ये retrograde cystogram, you know what is it? You don't know? देखो, एक basic point याद रखो. This will, when I was at your level, I also had this doubt. What is anterograde investigation and what is retrograde investigation? I used to have cross confusion on that. Whenever you go against the flow of any organ's secretion, whenever you go against the flow of any organ secretion, it is the retrograde thing. Whenever you go with the flow of any organ secretion, it is an anterograde investigation. Okay? Whenever you go against the flow of any organ secretion, against, it is retrograde. When you go with the flow, it is anterograde. So in retrograde cystogram means what we do, if this is the penis, you hold the penis like this and insert a feeding tube just at the meatus, just proximal to the meatus, this much. And then you connect this infant feeding tube with the contrast loaded in the syringe. Right? You let the contrast be loaded in the syringe with the infant feeding tube. And then this contrast is going to go through the urethra and then it goes into the bladder. So this investigation, while this contrast is going through the urethra into the bladder, you are taking an X-ray. This is called retrograde cystourethrogram. Right? This is called retrograde cysto because you are examining urethra also and bladder also. If you just examine bladder, it will be called retrograde cystogram. Right? Now, in case of a bladder rupture, the extraperitoneal. Cystourethrogram. In case of a extraperitoneal rupture of bladder, the treatment of choice, very important, is Foley's catheterization. Simple Foley's catheterization. The treatment of choice of extraperitoneal rupture of bladder is simple Foley's catheterization. The treatment of choice for intraperitoneal rupture of bladder is exploratory laparotomy. The treatment of choice for intraperitoneal rupture of bladder is exploratory laparotomy with repair of bladder perforation, with Foley's catheterization. Exploratory laparotomy with repair of bladder perforation with Foley's catheterization. Simple Foley's. This is a rule of nature. Could you have asked this? देखो ये है. This is what is the problem. This is an injury. And what we are doing, we are just putting a Foley's catheter. Right? This is a beauty of nature. That if you keep the distal passage of any organ patent, the lateral opening in any organ close on its own. So by putting in a Foley's catheter, what we made sure that the distal passage of bladder is patent, and this lateral opening will close on its own. But in case of this, we could have done in an intraperitoneal bladder also, because any lateral opening will close if you keep the distal opening of that organ patent. So this we could have done in intraperitoneal also, but we didn't do that because in this intraperitoneal bladder, the urine is going into the peritoneal cavity. For that, we have to evacuate that urine. So that is why we did a laparotomy. Then comes urethral injury. That is? नहीं डिस्टल ओपनिंग जो है किसी भी ऑर्गन की, अभी यहाँ से आ जाएगा मैसेज हिंदी में बताया था, किसी भी ऑर्गन में जो उसका नॉर्मल फ्लो है, अगर उसको आपने मेंटेन कर दिया कंटिन्यूअसली बिना ब्लॉक के, तो उस ऑर्गन की लैटरल ओपनिंग हमें अपने आप बंद हो जाएगी. ब्लैडर का नॉर्मल पैसेज है यूरिथ्रा और उससे बाहर. आपने यूरिथ्रा और ब्लैडर के अंदर एक Foley's catheter डाल दिया. When you put in a Foley's catheter in bladder and the urethra, you have made sure that the distal opening of the bladder is patent all the time. So it is now open. So this lateral opening will close on its own. Right? Then comes urethral injury. In urethra, there are two parts of the urethra, anterior urethra and posterior urethra. There are two parts of the urethra, anterior and posterior. Now, can anybody tell me what all parts of the urethra comes in anterior urethra? What all parts of the urethra comes in posterior urethra? Anterior urethra includes penile and bulbar part, penile and bulbar part. Stop. Penile and bulbar part. Posterior urethra include prostatic and membranous part. Now, please understand, very important, because this is a very important question for you, and this can come in exam. The mode of injury guides us about the type of injury inside. If there is a pelvic fracture, I told you, there can be an extraperitoneal bladder and there can be urethral injury also. And once there is a pelvic fracture in urethra, more commonly which get injured is membranous urethra. The membranous urethra. More commonly which get injured is membranous urethra. So once a pelvic fracture is there, think of membranous urethral injury and bladder injury. And how clinically you will be able to make out whether it's a urethral injury or a bladder injury, we will come to know. But if there is an injury called straddle injury, very important. What do you mean by straddle injury? Anybody? Very good. Whenever you fall on perineum, whenever you fall on perineum, many of you must have, tried to do cycling in the initial days. When you are learning cycling, that time when the cycle is a rod hoti hai. If you bang on the cycle rod on the perineum, that's a perfect example of a straddle injury. So whenever you land on perineum, whenever you get hit on perineum, that type of injury is called a straddle injury. Okay, and that mode of injury suggests that there is a bulbar urethral injury. Okay, so whenever a pelvic fracture is there, think about a bladder and the urethra. Whenever a straddle injury told to you, think about a bulbar urethral injury. But how will a patient of urethral injury is going to present to us? The patient is going to present to us with, can anybody tell me what will be the presentation? Non-passage of urine. Non-passage of urine, right? This non-passage of urine was there in bladder rupture also. What will be the difference? Patient here also will have a suprapubic pain. Suprapubic pain. But the classical thing here will be to pass urine. Right? And then there are certain signs also. What are the signs of urethral injury? We should be very careful about them. The signs of urethral injury are blood at meatus. Whenever you find blood at meatus, think of urethral injury. Second, whenever you find penile swelling, again think of a urethral injury. In trauma we are talking about, okay? In context of trauma. Whenever you find a scrotal hematoma, then also you should think of urethral injury. And whenever you find high flying prostate. What do you mean by high flying prostate? You will not see prostate flying high in the sky. High flying prostate means you fail to palpate prostate on DRE, digital rectal examination. When you fail to palpate prostate on a digital rectal examination, whenever you fail to palpate prostate on a digital rectal examination, this is called high flying prostate. Or whenever there is a pelvic fracture, I told you we should always think of a urethral injury. And in which urethral injury? And whenever there is a straddle injury, then also we should think of a bladder, a urethral injury. Okay. Now, investigation of choice in digital rectal examination. Investigation of choice is retrograde ureterogram. investigation of choice for urethral injury is retrograde urethrogram. Investigation of choice for urethral injury is retrograde urethrogram. And the treatment of choice for this injury is suprapubic cystostomy. Treatment of choice for urethral injury is suprapubic cystostomy. You have to put in a catheter into the bladder, but by suprapubic route. From the suprapubic route, you will put a catheter, not through the urethral route. Okay, and in case of a bladder rupture, important point, sorry, in case of urethral rupture, there is also sometimes there is a sign. Let me tell you that. First of all, this sign is there in a bulbar urethral injury per se. What is that sign? This is a sign specific to bulbar urethra. Please understand this. You all know penis has 3 tubes. Penis has 3 tubes: urethra, corpora cavernosa, and corpora spongosa. Penis has 3 tubes: urethra, corpora cavernosa, corpora spongosa, and then this corpora spongosa is covered by a fascia called Buck's fascia. This corpora spongosa is covered by a fascia called Buck's fascia. This is a normal anatomy of the penis. Now, what happens is, sometime in a bulbar urethral injury, if the Buck's fascia is intact, imagine there is a bulbar urethral injury happened in a patient and the Buck's fascia is intact. The injury doesn't involve the injury to the Buck's fascia. What will happen? The urine will leak out from the urethra, right? But since Buck's fascia is intact, the urine will not go further, right? So this patient will develop only penile swelling. Agreed? Agreed? Buck's fascia is intact, urethra is leaking, and the swelling will only be in the penile shaft because Buck's fascia is intact. Now, if injury has happened in such a way to the patient that the Buck's fascia also got injured, the covering fascia also got injured. Now, this time when the urine leaks out from the urethra, it will not be confined to the penis. Sorry. It will not be confined to the penis. This urine will go into the scrotum. So patient will develop scrotal swelling also. And the patient, the urine can go into perineum also. The urine will go into the perineum and the urine will not go beyond perineum because of a fascia called Cooley's fascia. And from there, the urine will start ascending up and come into the anterior abdominal wall. And then it can reach up to the clavicle. So you will find patient floating in urine. This extravasation of urine which has happened is called butterfly extravasation. This extravasation to bar khada bar hai to nahi to chodo. So this extravasation will be called butterfly extravasation. क्या है? नहीं टिश्यू में चाहिए. Butterfly extravasation. Okay. Now, so what I'm trying to convey, please understand, if the Buck's fascia is intact, there are 3 layers: urethra, corpora cavernosa, urethra is covered by corpora cavernosa, corpora sponjosa, and then there is a Buck's fascia. If the injury has happened in such a way that only urethra got injured, Buck's fascia is intact, then the urine will leak out, but the urine will be confined to the Buck's fascia only. So the patient will only have a penile swelling. But if the Buck's fascia gets injured, the urine will not only be around the penile. This is already there. Thank you, but so urine will not only be around the penile star. This urine will come into the scrotum, will go into the perineum, and from perineum it will ascend up and go into the anterior abdominal wall and reach up to the clavicle. This extravasation of urine is called butterfly extravasation, right? And this happens when the Buck's fascia gets right. So this sign also is important for us to know. Now comes a very important question. This was the question asked in a recent NEET exam also. Listen to the question, it's a very good question. And this kind of thing happens in your emergency commonly. That is why they ask this question. And you may come across this in your casualty when you are working as an intern. A patient comes to you saying that I fell on perineum while trying to learn cycling, right? And I have a blood coming out from the meatus. So when you examine, patient has a blood at meatus, right? So what are you suspecting? You are suspecting a urethral injury. Agreed? Now, when you are suspecting a urethral injury, what do you expect from this patient to tell you in the clinical symptoms? That I have not passed urine, right? And I have a strong urge to pass urine. So you have asked this question to the patient. Patient says, just before the cycling, I had a urination, I did a micturition. And after that, I didn't feel like, so I didn't do anything. And after that, I got injured. So I don't know. I have not tried that. Okay. Now, this patient says, I don't know, because I don't have any problem at this moment. I just have a blood stain at the meatus. So what do I do? What will you do? What should you do? देखो इस सिनेरियो में अभी पेशेंट को पता ही नहीं है कि उसने यूरिन पास करना है, करेगा, नहीं कर पाएगा, उसने ट्राई नहीं किया है, और आपने सुप्राप्यूबिक रीजन पे परकशन किया. You have tried to do the percussion on the suprapubic region, and there is no dullness still. So that means the bladder is still not still full, because urine is still building up. So what to do in such situation? You don't know that whether this injury will lead to a retention of urine or not, because imagine the injury is such, this much injury, just this much. The patient had a urethral injury, but very small urethral injury. So this urethral injury may not cause any problem in the micturition. So what will you do? You will tell your patient to stay in the casualty, wait, see to it whether you can pass urine on your own or not. So wait for the bladder to get full, and after that, if the patient is not passing urine, suprapubic bulge comes, then only you have to do the investigation in the form of retrograde urethrogram and suprapubic cystoscopy. If the patient passes urine on his own, the injury was so minor that we don't need to do anything. So in all such situations, we just have to wait. You don't have to be in a hurry to do the investigation or do a suprapubic cystoscopy. But yes, if the patient already has a retention of urine because of the injury, suprapubic bulge is already there, patient has a urge also, you have to do a suprapubic cystoscopy. Everybody understood? Okay. Then comes a new question in the series of trauma questions, which is a question on penile fracture. Penis never get fractured when it is flaccid. Penis only gets fractured when it is erect. Penis only gets fractured when it is erect. So this patient will come to you with a classical complaint that during sexual intercourse, this is a classical presentation of this patient, that during a sexual intercourse, a click sound came, and the penis got swollen. A click sound came and the penis got swollen. On examination of these patients, you will find S-shaped deformity of penis. You will find S-shaped deformity, which is also called eggplant deformity. S-shaped or eggplant deformity of the penis. And the important point to note in this injury is urethra rarely gets injured in this injury. Urethra rarely gets injured in this injury. It is a corpora cavernosa and spongiosa which gets injured. It is the corpora cavernosa or spongiosa gets injured in this injury. And the same rule is applicable here also. If the buccal fascia is intact here, if the injury happened in such a way that the buccal fascia is intact, here urethra since is not getting injured, so urine will not extravasate. What will extravasate? Blood. So in this scenario, there will be blood inside the buccal fascia. So penis will be swollen because of a blood inside the buccal fascia. But if the buccal fascia gets injured, this blood can even reach clavicle. Butterfly extravasation here also will happen, but not of urine, but of blood. And the treatment of this injury is immediate repair. The treatment of choice for this injury is immediate repair, and the investigation of choice for this is ultrasound. Repair कैसे करेंगे? Suture से, right? Investigation of choice is ultrasound, and the treatment of choice is immediate repair. This was about a penile fracture. Then comes seat belt injury. क्या बोला? कर रहे हैं, ऑब्जर्वेशन कर रहे हैं. कुछ करने के लिए थोड़ी कुछ करना है, समय बिताने के लिए करना है कुछ काम टाइप. हाँ, चलो करें डांस करना. ऑब्जर्वेशन, बस ऑब्जर्वेशन. मैं चुप करके बैठ जा, ऑब्जर्व कर रहे हैं कुछ. ये ऑब्जर्वेशन भी कुछ करना ही होता है, ये जरूरत नहीं है. राइट, ठीक है. Then comes seat belt injury. She was asking, तुम सोच रहे हो कि क्या बातें कर रहे हैं आपस में? She was asking कि sir, since we are observing this patient, why don't we do ultrasound to find out if the bladder is full or not, or like that? Because patient can say that you are not doing anything. So we should not be doing something just because patient wants to get something done. You can tell your patient that observation is also something which we are doing. So observation is not that we are just time pass kar rahe. It is also a treatment modality sometimes, right? Seat belt injury. Now, wearing a seat belt decreases the mortality of the driver though, but wearing a seat belt can have a certain pattern of injuries also. And it's a very commonly asked question in exam. What is the most common injury due to seat belt? The most common organ injured here is mesentery, followed by proximal jejunum, followed by distal ilium. Then we should also know something about a blast injury. Very commonly this question comes in exam. In blast injury, what is the most common organ injured? The most common organ injured is the one, all those organs which have air inside them are the most vulnerable organs. And the most common organ which get injured here is tympanic membrane. If tympanic membrane is not there in your choice, then it will be lung. If lung is also not there, then it is stomach. If stomach is also not there, then colon, and then the small intestine. Least vulnerable organ, please note, least vulnerable organ are all those which are solid organs. Solid organs are the least vulnerable organs. But they have asked this question many times when they asked what is the most common organ injured in a underwater. Blast injury. When the blast happens underwater, submarine injuries. Underwater blast injuries, the most common organ injured in an underwater blast injury is same sequence is there in underwater also. But please be very careful if you are told that the face is outside water and the blast happens. If the underwater blast injury is there, but patient's face is outside water, then the sequence will start from lung. But if the upper trunk is outside water, then the sequence will start from stomach. So depending on how much body part is submerged in water, the sequence will be decided on the basis of that. So if whole body is inside the water, the tympanic membrane, lung and all will be injured. But if face is outside, then it will be lung. If upper trunk is outside, then it will be stomach likewise. Right? Then comes another very important thing, and that is about, this is a very important and a potential question in exam, a clinical thing. It depends on how much body part is submerged in water. If whole body is submerged in water, then the same sequence will prevail. But if face is outside water, then the sequence will start from lung. And if the upper trunk is outside water, then the sequence will start from stomach. Okay. Now another very, very important question, which as an intern or as a duty doctor, we should know how to identify. And that condition is called compartment syndrome. This condition is called compartment syndrome. And what is this compartment syndrome? How will the patient is going to present to us, and what are we supposed to do in such situation is a very important thing. First of all, you all must be aware through your anatomy and orthopedic discussion that in our limb there are compartments, right? And if the pressure inside the compartment increases because of anything, the nerves and the vessels present in that compartment may get compressed, and when the nerves and vessel get compressed, the blood supply to the distal part obviously will get compromised, and when the blood supply to the distal part get compromised, the patient may develop gangrene of the distal part. So when does this happen? What are the scenarios where it will happen, and how should we suspect that? Because if we delay in treating a compartment syndrome, we may lose the limb. So we have to be very vigilant, very conscious about this fact that compartment syndrome is a very important entity, and we have to do something about it immediately. Now, in what scenario you should be suspecting it first? One, can you tell me what is the most common cause of compartment syndrome? Was it discussed in your ortho classes? ऑर्थो में हो गया है तो उसमें अच्छे से बता दिया होगा तो ओके एनीवे जहां पे नहीं हुआ जिनके लिए ऑर्थो की क्लास होगी तो ऑर्थो में होगा मतलब ये डिस्कस तो छोड़ो I'll tell. Now what is the most common cause of compartment syndrome? The most common cause of compartment syndrome is fracture. Now can anyone tell me that this will happen in a closed fracture or an open fracture? Can happen in closed or open? It can happen in both. Can happen in both, but it is just that it is more common in closed. So it is not that you should be suspecting a compartment syndrome only when there is a closed fracture. You should suspect even when it's an open fracture. So one scenario is this. Any other reason where we can have a compartment syndrome? There are compartments in our limbs, right? These are called osteophaseous compartments, right? These compartments have various vessels and muscles and nerves there in that. If the pressure inside this compartment gets increased, there will be a compression over the vessels and nerves in the compartment, because of which the distal part of the limb may get a poor blood supply, leading to gangrene. This is what is compartment syndrome. When does it happen? It can happen when there is a fracture of the bone, be it a closed or an open fracture. Second reason of compartment syndrome can be tight plaster cast. Where else it can happen? On burns. Very good. Where else it can happen? Whenever there is extra extravasation of fluid in compartment. When does that happen? Aapko bola, you are told to put a cannula in the vein. You had a difficulty in putting a cannula. You could not locate a vein and you put a cannula inside the fascia. The compartment will get filled with the fluid and the compartment pressure will increase. Right? So in such situation, and there is fifth also, reperfusion injuries. In such situations, patient develops a compartment syndrome. Okay. Now, how to suspect it and what to do about it? The patient will come to the most common presentation of these patients is severe pain. Patient will come to you with a severe pain in the limb. But when you examine the limb, you may find the limb is absolutely normal. And you may presume that the patient is malignary. And it is this time, if you have not done anything, we may lose the limb. So, how will we know if a patient is complaining of severe pain? Is it pain because of a compartment syndrome or because of something else? So, the earliest sign of compartment syndrome is pain on passive movement of the or passive stretch or movement. If the pain is happening on passive stretch or movement of the limb, it means the patient is developing a compartment syndrome, right? Then if you miss this part, later on the patient may develop paresthesia, may develop paralysis, and may develop pulselessness also. This pulselessness is a last sign actually. These are the late signs. These are the late signs, right? And if any of these are there, moment this is there, or any of these are there, we should not waste any time. We should immediately release compartment. How will you release compartment? You will release compartment by doing fasciotomy. You will release compartment by doing fasciotomy. What is fasciotomy? Otomy. Fascia is a solid thing. So you will divide that fascia. Now, what is a very important point in this is, how will you know that you have done a complete releasing of pressure of the compartment? This was a question asked in your exam. In fasciotomy, you will give incision on the skin. You extend your incision to the subcutaneous tissue, then the superficial fascia and the deep fascia. How will you know that you have incised the deep fascia or not? The moment you incise deep fascia, you should see the muscle bulging out. If you see a muscle bulging out from the compartment, it means then only you have released the pressure from the compartment. So, in compartment syndrome, we have to identify first that the compartment syndrome is happening, and then we have to immediately release that compartment by doing fasciotomy. We should also do fasciotomy when the compartment pressure in any compartment goes above 30 mm of mercury. Once a pressure in the compartment goes above 30 mm of mercury, then also we are supposed to release the compartment by doing fasciotomy. Then comes compartment pressure. We measure by putting probe inside the compartment. Pressure probes. Huh? No. Probe is just measuring the pressure. It will not release a pressure, the compartment pressure. It will just measure a pressure. आपको कोई एयर थोड़ी है जो लीक होनी है वहां से, pneumothorax थोड़ी हुआ हुआ है ना. Then comes scores in trauma. Now, most commonly followed score in trauma is TRIS score. Trauma, injury, severity score. Trauma, injury, severity score. In this trauma, injury, severity score, this score is a score which helps in predicting outcome in patients of trauma. This score helps us in predicting outcome in a patient of trauma. Now, what are the parameters in this score? We should know. We just need to know the parameters. Age, revised trauma score, and we have injury severity score also. Age, revised trauma score, injury severity score, and now mechanism of injury is also added in this. These are the four parameters there, and one should also know revised trauma. ज़्यादा डिटेल में नहीं जाना है, सिर्फ इनके पैरामीटर्स पता होना चाहिए. Revised trauma score has 3 parameters: Glasgow Coma Scale, respiratory rate, and systolic blood pressure. Right? These are the parameters there in a revised trauma score. And this TRIS score is there to predict outcome in a patient of trauma. Another very important point. As I said, that I'll be giving you the things here so that you can answer any question, but at the same time, you don't have to remember many things. Right? Now, regarding the hormonal changes in trauma. What are the various hormones which are going to increase? What are the various hormones which are going to decrease in trauma? You can take it from here. A very simple. All hormones except these 3. Insulin, thyroxine, and triiodothyronine. Insulin, thyroxine, and triiodothyronine are the 3 hormones which are going to decrease in trauma. Rest all other hormones, and one more you can take, androgens, are going to decrease in trauma. Rest all are going to increase. As simple as that. Insulin, thyroxine, triiodothyronine, and androgen. These are the hormones which are going to decrease. The rest all hormones are going to increase. As simple as that. Right? Another thing about trauma. In trauma, whenever a patient has a trauma, for first 48 hours, there is a first phase of trauma. From 48 hours to 10 days, there is a second phase of trauma. And from 10th day to 60th day, there is a third phase. This first phase is called ebb phase. This second phase is called flow phase. What we need to know for our examination point of view, flow phase is a catabolic phase. And then the third phase is a anabolic phase. So there is ebb phase, there is flow phase, there is anabolic phase, right? What we need to know at our level, second phase is a catabolic phase, which is called flow phase. And this flow phase lasts for 48 hours to 10 days. And then after 10th day of trauma, the anabolic phase starts and it goes up to 60th day. Right? Just for your understanding, no need to know that what is happening in ebb phase. Ebb phase is a phase after trauma where body prepares itself to withstand trauma, and then the catabolism actually starts. But at our level, not required how the body prepares, what all things happening. Just need to know that catabolic phase is a second phase, not the first phase. The first phase is the ebb phase. Okay. And one thing more one should know here, in trauma, the immune function of the body also decreases. immunity of the body also decreases, right? So there is lymphopenia happens, and there is neutrophilic dysfunction also happens. But just one thing, remember, out of all the inflammatory cells we have, the only cell which increases is monocytes. Monocytosis happens. There will be neutrophilic dysfunction, there will be lymphopenia, but there will be a monocytosis happens in a trauma. This is all about our discussion on trauma. Trauma is very traumatic but very important. Right? So let's take a break for half an hour.